Hey, everybody, welcome back to the We Fix Pain podcast. This is episode number 28 with Dr. Greg Lehman. Am I saying it correct, Doc?
I think so. It's a big debate, so I don't
All right.
care.
I was going to say, please correct me if I'm wrong. Doc is a chiropractor and physical therapist, and he's come up with some awesome and amazing content for a course with the course called Reconciling Biomechanics with Pain Science. And we're going to get into that topic here in a little bit. But first, let me introduce the podcast and the purpose of the podcast. Our podcast focuses on health and wellness related topics with a specific focus on integrated neuromusculoskeletal care. We discuss injuries to muscles, tendons, ligaments, joints, fascia, bones, and nerves that lead to pain and pain-related conditions. We address on the podcast topics like assessment, diagnosis, treatment, rehabilitation, and management of acute and chronic related pain conditions. We thank you, our listeners, for making the podcast what it is. We humbly ask, if you like the material, please subscribe and share. Your comments are appreciated. Dr. Lehman is a physiotherapist, chiropractor, strength and conditioning specialist treating musculoskeletal disorders. He has created two-day courses, continuing education courses taught to health and fitness professionals around the world. The one that we're going to focus on is called Reconciling Biomechanics with Pain Science. That is an important topic in the clinical rehab world. And the second course called Running Resiliency. We'll dive into that just a little bit, but that will not be the focus. Dr. Lehman is trained in Occupational Biomechanics Laboratory at the University of Waterloo. He's published more than 20 peer-reviewed papers in manual therapy and exercise biomechanics. He was an assistant professor at the Canadian Memorial Chiropractic College, teaching graduate-level courses in spine biomechanics and instrumentation, as well as conducting additional research in there. His philosophy and his goal and his beliefs are successful injury management and prevention. We use simple techniques that address multifactorial and complex nature of musculoskeletal disorders. Doc, thanks again for your time and in advance your talents.
Oh, yeah. Well, thank you for having me. Technically, I'm not a chiro anymore. I let my license go I still went to school there and did all that stuff. But in Canada, the overlap is so huge. There's no point. And it costs so much more to still have a license as a chiro. I was like, there's no point.
I appreciate that. And I've toyed around in the past, 5 years or so with letting my first training and my first certification and my second training and second certification as a strength training and conditioning coach, as an athletic trainer, whether I let that lapse or not, for the exact same reasons. Day in and day out, I don't do much of that anymore, but it's important and informative in how I view things and how I see things. So I get it.
Yeah.
Doc, let's go into the topic of reconciling biomechanics with pain science. So let's start with a 30,000-foot view. What is this topic, and why the content that you created for the course?
So it probably started, 15 to 20 years ago. There's a lot of debunking going on in the field, like say VMO with the kneecap pain or something like that. The classic physio thing is the VMO is delayed and that's causing a problem. Or in the spine, people would say the transverse abdominis isn't firing, or the multifidus or something like that. So there's a lot of debunking 15, 20 years ago saying, that's really not the problem, those things. Those are, they look like they're the issue that's causing pain. They're sometimes associated with the pain problem, but they aren't really the issue. So there's so much debunking, and then people are like, well, it's easy to debunk and to criticize these things. Well, what do? And hence that was the impetus for the course. It's like, you don't have to throw out the treatments that you're doing. Like, so with knee pain, instead of saying the VMO is dysfunctional, you would just say, well, I can use a lot of the same exercises or the same approach, whatever it happens to be. And you acknowledge that it's helpful. It's just helpful for another reason. And that's the reconciling biomechanics or reframing biomechanics. Like, let's find the good in here. And then there's a lot of newer pain research that would throw people for a loop, it would be, and none of it's new. I could have said the same thing in the 90s, that like a pain science idea would be structures, not destiny, right? Meaning we know you can have these structural changes on a scan and someone could be pain-free. So how do you reconcile that with the problems that people have, and then the treatments that you do? So that's the whole big picture view, saying we still do good stuff. Just let's look at it differently and then simplify it. It's
Yeah, I
easy.
think over time, our explanations, while although well intended, were not well researched. And then over time, our explanations for why things work, how things work, inadvertently can create harm in patients if we keep hammering those things over and over and over. Is that a fair assessment of?
Potentially. And sometimes I push back against that. And these would be more of my colleagues who are the pain science based approach, who believe beliefs really matter and, we're causing harm with the words. And I'm like, if we view the spine as strong and stable, I also view people as strong and stable. And a lot of people can tolerate a negative view about the back. And so I would say lots of people are okay hearing their joint is out of place and they're not going to have pain. But then there's a subset of people, sure, their beliefs and their thoughts and their emotions could really contribute to their disability and pain. So yeah, it's true, but I think like time and place, like everything else, we're not that frail,
So
both
contextually
physically and
dependent is what you're
emotionally.
saying.
What's that?
Yeah,
Sorry.
it's true.
Yeah.
It's all contextually dependent is what you're saying with, yeah.
For sure. Like, and we know that. Yeah. Oops.
Doc, you mentioned this concept of pain science. Now we have some of our listeners who will know what this is and have read some of the books and trainings, some guys like Mosley and Butler and some of the other outstanding works that it's out there. But for the novice, what is this topic of pain science? How do we describe it? How do we broach this with our patients?
I mean, okay, so there's two things in there. What pain science is just the science of pain, like of why things hurt. So it can be very mechanistic, and then some it would go way before Mosley and Butler and all that stuff. And you're talking like Melzack and Wall and all of these old, not old, but they've since passed away. Neuroscientists studying about why things hurt. And so, I mean, really, the biggest implication of pain, the science of pain research in the past 50 years would be it's just more than tissue, right? It's more than something happening in the tissue, and that but it's not that the tissues are irrelevant, that's for sure. It's just that for whatever reason, maybe there's some signal in the tissue that suggests it's irritated, and then something happens to that. It gets processed at the spinal cord, it gets processed at the brain, it's influenced, and then that biology or that physiology is influenced by so much more than just the simple signals in the tissue. And that's where people would want us to think about fear, worry, stress, all of these things. So the idea of pain science would be like it's multifactorial, right? Where tissue is just one thing, albeit a very important thing. That would be the
So
crux
the
for your patients.
combination of tissue nociception, sensitivity of the tissue, in combination with the external factors, what we perceive, what we think, what we feel, our external environment. Is it sunny here in Austin, Texas versus cloudy? I had some people last week, believe it or not, who had started to have seasonal affective disorder here in Austin because we'd gone a whole week without sunshine. And I was like, try living in Chicago for 4 months of the year, right?
Yeah.
So all that matters.
Yeah, and then that's it. And then I mean and this is where the science would have to come down. People would look at it. I still think that the tissue is often involved, and you have signals from the tissue, and I think that the psychosocial part has a physiological component that it would influence. The physiology of pain or nociception and all those things. So it's very intertwined. Like when you talk about the biopsychosocial, they're not distinct and they just overlap.
Gotcha. Now, you mentioned a key buzzword here, the biopsychosocial model. I would assume most of my colleagues know what that word is, but for the novice, how would we describe what is biopsychosocial model in clinical rehabilitation? What is this term?
Yeah, so I don't get into the weeds on this stuff. All it to me, I'm a simpleton when it comes to this. I just want to think about more factors when it comes to someone in pain than just their structure and their tissues, right? That's it. It's just knowing that so many variables in someone's life, who they are, can influence the suffering and the pain that they have. That's how I think of it. And I think it's really hard to like split things up. Like people would say, you can never just treat the knee. You have to always think of the psychology. And I'd be like, okay, run with that. That would also mean any intervention that you do that's physical would also be influencing their psychology, right? Like it's such a mess to parse these things. So you just want to think bigger would be the
Yeah,
idea. And it can be frustrating because it's not so linear, And then you can't say this is exactly why someone hurts. And you just have to accept that murkiness. It's like saying, why am I sad today? Or like, why am I feeling a little bit unwell? It's really hard to parse those things, exactly what's going on. But you don't need to parse those things to do something about it. Same with
Yeah,
pain.
it's reductionist thinking in our neck of the woods that only one thing or one problem, whether it's the biology or the environment, is triggering pain. And it's really a complex interplay of a little bit of both of them, it seems. And we don't need to kind of try to assign more blame. We just need to know that this is happening and have useful interventions that are relative to what the patient needs, wants, and their goal.
Yeah, yeah, exactly. I do a little thing in the course. I pull up a slide that sort of lists all of the factors associated with pain, the bio, the psychosocial. It goes more into that. And I'm like, physios, chiros, movement practitioners, strength coaches. I really think we're the best people to do it. Because someone can, if I can give an example, fear and catastrophizing would be huge variables that we can kind of measure. We assume that they're associated with pain. The assumption is they actually mediate recovery, meaning if they change, the pain and disability can change. So it seems to be an important one. And those are psychological factors, but it doesn't mean the intervention is psychological, right? It's starting to do more of the things that you love again. If you're afraid to bend your knee or bend your back, then you do those things. So physical interventions, can have these psychological effects, right? Or when it's related to fear, depression, anxiety. So we're not going to be treating straight up primary depression, but if it's anxiety, depression associated with a belief about their back, then we are totally the right person because that belief is often associated or related to tissue being injured, right? Who's the best person to reinforce to someone that your tissue is robust and strong and it can adapt to these loads that we place on it, but us, right? So this is what I mean by the interplay and looking at it this way.
Yeah, and case in point is several months ago, I had a lady that 1 year post fracture of her distal fibula, and she still can't walk more than 10 feet, and she's afraid to walk more than 10 feet. So leaving her house is really a really scary proposition. And you look at all her extenuating factors, severe anxiety disorder, she's been hospitalized, and all of that. And after X-ray, your fracture is healed. I saw her a year and a half after the fracture. It's healed. It's healed. Healed. We have no idea, but nobody ever told her that this is fear avoidance. And kind of like, in the psychology world, you have to take a step towards something that is potentially mentally draining, mentally taxing. This is, I'm forgetting what the psychology term is, but if you have a spider, you walk towards the spider rather than away from the spider. And then you take another step, and then you take another step, and then you take another step. So my simple rehab program was easy. I'm not going to do any manual therapy. I'm not going to do any rehab. I'm going to see you this week, and I want you to walk to the mailbox. Your goal is to make it to the mailbox, and then report to me next week. I hurt. And I was like, did you make it out of your house today? Yes, that's a win. And did you hurt worse? No. And then next week, I need you to walk 2 blocks. And then the next week, I need you to walk a mile. The next week, I need you to walk. Did you hurt every step? Yes. So you walk for 2 miles and you hurt the same amount as you just sitting in your house. Tissue is fine. And really, you're using that physical exercise to really train the brain. So the interplay between the two is massive
Yeah,
and huge. And
yeah,
that's to your
and
point.
sorry, go ahead. Yeah,
Oh, no, that's to your point. It was a
yeah.
physical treatment that had a physical and psychological impact.
Yeah, the psychological term is just graded exposure or
Oh,
any
yeah, my
exposure.
fault.
That's okay. It's just Valayan is the one to read on this, but they would call it like a behavioral experiment, and it's all like contingent upon the idea of like associative learning and all of this stuff where you break, you replace the link between some activity. You expect something bad to happen, and then when you do that activity and that bad thing doesn't happen, it makes you challenge the association between the two, and they call that a violation of expectation. And then what you did was sort of a little bit of both. Some people might call that graded activity. I don't care like the debates here. But what this is the whole point of reconciling biomechanics with pain science is like what you did there, you both had psychological effects where maybe her recovery was mediated by changes in fear. But without a doubt, her loading that bone in the tissues has physiological effects and structural effects on that. And her poking into pain would have neurophysiological effects via habituation, meaning if you get the dose right and you poke into a painful activity, our conditioned pain modulation and descending inhibition of nociception at the spinal cord, then she does the same activity with the same amount of pain, or she does more activity with less pain. So That's cool pain science to me, or
Yeah.
biomechanics. I don't
And
know,
it,
both.
and to your point, the modality is the same, exercise. The effects can be a little bit different, neurophysiological versus tissue based. But to your point, why are we suited for both is because we have tools in our arsenal that can address both components of it.
Yeah, yeah. And some of it might be like doing something physical like that. There's also the sales associated with it, and that's the psychology and working with people and all of that,
When
getting
do
trust.
when do anatomical things, and I have a list of things I want to ask you about. When do things matter and when do things not matter? For example, like osteoarthritis. We know
Yeah.
in some it can be limiting, can be self-limiting, or can be physically limiting. We know moderate arthritis may not be painful, and significant arthritis may not be painful, but you may have limitations. When do things like in an anatomical flaw or degenerative changes to the joint, when do those start to matter, and when do those, hey, this is a normal part of the aging process, like a wrinkle? When is that point?
I don't know. I mean, I would guess it's based on an inflammatory component. That would be my thing. Meaning you can have structural changes, degeneration, all of that. And if there's no inflammatory thing sensitizing the nociceptors, right? Like those might end up being pain, those signals aren't created, then then it may not be associated. So with osteoarthritis, like it's weird. You'll see former athletes, high level athletes in some studies, they do have more changes on their scan when they're older, but they have less pain. And then other things, high level athletes, like not in runners, let's say like soccer, they'll have more changes and it can sometimes be associated with more pain. And then you dive into like the literature on OA, and one of the variables often associated with knee OA is bone marrow lesions, right? So bony edema. And that seems, and
Bone marrow
if,
edema.
yeah. And if that's in the knee, although bone marrow edema in the foot, like in runners, doesn't seem to be associated with pain at all. You see it like so consistently in elite runners and after marathons. But in the knee, it seems to be something. And the idea is that it's some sort of synovitis or some sort of inflammatory thing going on. So I always view structural changes as, my analogy is like kindling for a fire. It's not enough for a fire, but it probably nudges up your likelihood of having that fire and having that pain. It's same thing with tendinopathy. If you have tendinosis in an Achilles tendon, which just means the tendon, the structure has changed, not as healthy as it could be. Those athletes who have that when they don't have pain, if you follow them over a couple of years, they will be more likely to have pain. Not doomed to have pain, but their likelihood of that turning into a painful tendon is increased, right? So I like to think that they're relevant, but to me it's all the more it's all the more case. It's all to look at this biopsychosocial in the whole person. So you want to make them as healthy as they can be to tolerate these little structural things that might nudge up their likelihood of having pain.
Yeah, I remember reading an article a couple of years ago, in addition to the local inflammatory response, when they also start to do scans of the spinal cord and those tracks, that they're more likely to see sensitization in the brain and spinal cord to make an active osteoarthritis painful and limiting, versus those people who have the same amount of degenerative changes don't have those markers on scans in the brain and spinal cord as well. Yeah, it's really interesting, the interplay of that.
Yeah, and if we go into the weeds of that, like, so that you could say, so someone might be more prone to that. They have a more sensitive nervous system, and they're more prone to sensitivity in the spinal cord. And then other people would say, well, no, that's because there's something in the tissue that has not, like central sensitization, how originally was discovered is you create an injury in the tissue. So you're sending nociception into the spinal cord. And the way the spinal cord adapts, like what we do as humans, is we amplify it. It's a protective response. It's how you stop walking on a broken ankle. But the assumption here is it might become pathological after a while. So who knows, the chicken or the egg? But that's it. There is higher likelihood of sensitivity when it is more, maybe.
One of the things I've seen more and become more and more and more aware of, especially in my time here in Austin, we're a very active city, Austin, Texas, and I've seen more hip and labral pathology here than I had seen in my, I don't know, 15 years prior working in the Chicagoland area and the Chicagoland suburbs. So when does anatomy and structure of the hip joint either A, lead to pain, or B, hip socket, hip depth leads to performance enhancement or performance reduction in certain sports? When does the hip anatomy matter?
So it's funny, I'm just rewriting a lecture. It's done, and now I'm just reviewing, so I know a cold, so I don't know a cold yet. But the hip is a bloody mess. So if you take an asymptomatic group and then someone who has hip pain, you can see more labral pathology or CAM or impingement. But then you take a group of like athletes and hockey players who are asymptomatic, then they will have all of those structural changes almost as much or comparable to the symptomatic group. So yeah, I don't know. This is our challenge. Like I don't think anyone's at this. I know people are working on it, especially in the spine. I just don't think you know. And one thing, there's an older paper, a few years old, like when people had femoral FAI, the femoral acetabular
FAI.
impingement. Um, they looked at their range of motion, and the thing that correlated with active range of motion or passive range of motion wasn't the amount of structural impingement, it was just the amount of pain. So it's a mess. It doesn't always even, I mean, I would totally believe that FAI would affect your function, but pain is also a big factor here too. So I can't answer that. It's honestly like it's sort of one of my favorite clinical questions is like, when is this specific thing really relevant? Or when do you need to be really specific? You know, like when does a person need a knee replacement? Because some people definitely do. And we don't know that that's the thing. Like, because a lot of knee replacements now, if they follow them for 8 years, a lot of the knee OA, I think the number is like 75 to 80%. They're stable. Like they have lots of pain and degeneration, and it just stays the same over 8 years. But then there's a subset who decline, and they should absolutely get the surgery. But you don't. You have no idea. So sorry to everybody.
Hey, Greg, depth of the socket in certain sports, for example, developing power at depth versus rotational, the ability to high speed rotate and pivot. Is there a specific hip type that we want to develop power at depth? Think about the snatches, the jerks, the power cleans, versus is there a particular type of hip that is more prone for rotational and pivoting sports like golf or tennis?
I mean, I'm sure that the biomechanics matter here, but to me, like, I don't know if in practice it matters, right? Because you're not gonna be able to change that stuff. And if someone loves a certain sport and their hips is the opposite one that would thrive in that, you're not gonna tell them to go do the other sport. Do you know what I mean? So like I never so to be honest, I'm like the worst person to answer that question because I don't really think that way. But
Yeah,
but but it wouldn't be bad if like if you're working with someone and they have like really deep hip sockets and they might not have a lot of internal rotation. And you could say, listen, you're never gonna get this. Don't waste your time here. And it's like, let's say it's golf. Let's focus on the other area. So I could see it being relevant there just to put like expectations on people. But I don't know how good we are at that stuff yet, of being that prescriptive. Because what if you tell someone, oh, you're not going to get it anymore, and then they could have got 10 more degrees, and it might have been important to them. So sorry, I suck there. I'm the worst person to answer that one.
oh no problem. It's an interesting topic. I remember Stu
Yeah.
McGill a couple of years ago talking about anatomy and depth of hip sockets, and I remember one time there was a podcast I watched or a video clip where he talked about exhuming corpses and looking at depth of your sockets. A lot of it's genetically mediated. If we exhume your corpses of your ancestors, that we would see serial similarities in that. And depth of the hip socket and power and rotational sports are two opposite things for what the hip wants to do. And the reason why I was going with that is because the next conversation is the butt wink,
Yeah.
right? So let's define it. What is this concept of a butt wink when you're picking up heavier loads or when you squat?
I mean, so when people squat, everyone's always starts to move their spine into flexion, their lower spine, even though it looks like it's not. So naturally, people will start flexing their spine, tend to. So the max lumbar spine that someone would have would be like around 50 degrees in the average person. When people start to squat, once they get to parallel, thighs parallel to ground, even if it looks very straight, they're probably around 10 to 15 degrees of spine flexion, maybe even more. And then there's that point where it looks like their spine is in neutral, and then boom, you'll see the pelvis go into a posterior pelvic tilt. So now the spine, if the pelvis is going, the spine is going with it. So now their spine might
For,
be,
for our viewers, this is the pelvis that sits here that starts to tuck under and kind of
yeah,
round like that, correct? Okay.
yeah. So like that, it would look, if you measure that person's spine flexion, it would almost be like they've bent over to touch their toes and let their spine round once you get that pelvic tilt. And most people will get it. Just depends when they get it, like in the depth of their squat. Some people had said, well, this is the hamstrings that they'll do that. No, because your knees are bent, so they're not pulling. Others would say it's like your pelvis has to get out of the way of the hip bones, right? So there, when you go posterior pelvic tilt, will just change the pressure on the front of the hip. Other people would say it's a function of how tight your glutes are, your hip extensors, right? So as if you're squatting and they come to a point your glutes are tight, they're going to have to the hips will rotate backwards for you to get more hip flexion, right? That's all it is. And then another argument is really with a lot of flexion, like if you look at a regular squat, you're just balancing, the weight of your butt and the weight that's in front of you. And we're all levers here. That's it. So at some point in time, in order to keep your equilibrium and your balance, if you tuck your hip under it, it lets you balance and not usually fall over back. Yeah. Like myself, when I squat, I don't have a lot of ankle dorsiflexion. And so I posterior pelvic tilt really early. If I go up, if I put my heels up, then it's a lot later. Yeah. So that's it. So, but
Yeah, you
people
kind
think
of
it, I actually don't think it's a big deal. I know people worry about it. I'm like, well, it's pretty natural to me.
and that was my next question.
Yeah, I
And
know.
people have associated. Yeah, you knew where I was going with this.
Yeah, well,
It's become
because that's the most important question. Yeah.
the boogeyman, right? So it's become the boogeyman, flexion, butt winking, flexing, especially with weighted objects. If you're going into a loaded squat and then you butt wink at or around or near your depth, whatever your functional depth is that a harmful thing or potentially injurious mechanism for back pain with a loaded squat?
To me, it is like the issue is huge, and it's been debated for literally 50 years. It's the classic stoop versus squat debate. And I'm cool with people. At some point in time, you just have to choose a side of the fence. And so I just want to preface this where like we can disagree on these things, and that would be normal. It would be weird if everyone agreed on that because the research is lacking. This is the thing. We would need a study that would follow 500 people who butt winked, okay, and squatted, and then another 500 people who didn't. But everything else in their life was the same, right? The loads that they lifted, the amount of training, how flexible they were in their training, their sleep, all of these things. You would have to do that. And that's just not going to happen. And you'd need
And you'd
that
have to
study
follow
done
it for years, like
for
10,
years.
15, 20 years. Yeah.
Yeah, so it's really really tough. You have to choose a side, and so to me, I've chosen the side where I think with all things being equal, worrying about a little bit of spinal flexion, because really, if you're not butt waking, or if you are, it's only 10 to 15 degrees. Although that's the thing, some people have argued that 10 to 15 degrees is really important because it changes the stress on the spine to a point where you're going to get injured. And I would rather have people focus on other things, how much they're training, their social life, their load management, how happy they are, their mental health, their nutrition, all of that stuff, getting a good coach, just training well and not worrying about that. And it's same with running. It'd be like saying 4-foot running is the wrong way to run because when you 4-foot run, it increases the load on the tibia because most of the force is coming from the muscles in the calf. Therefore, everyone should be heel striking because there's less loads on the tibia and we don't want to get stress fractures, right? That's true. There is more load down there. And you could say the same thing with spine flexion and the disc maybe, or the ligaments. But we would need like these pragmatic trials to really make those strong conclusions. And I just kind of have a personal philosophy that we can adapt provided we slowly build up to things. Then I say all that, sorry, almost done. And then I would say all that. But if things hurt, by all means, avoid butt wink for a little while. Or if things hurt with a very neutral spine, then go into some butt wink for a little while. So it ends up being a lot similar or simpler. If it hurts, maybe don't do it, and then build a tolerance to it in the future.
Yeah.
It's
Simple
all right.
approach there.
Nothing booming for your listeners. I
I'm
just
not
think
trying to create I'm not trying to create controversy. I just want to know where you kind of sit on the fence because I've heard both arguments, and I sit in the camp that for some, you're not going to train the butt wink away. So what do you do with it? You either load above it, or if you train into it, you make sure they're robust so that they don't further accentuate. I think it's at the time that the people are most vulnerable, they get a little bit of a shear, and it's not the flexion, it's the loss of whatever position. They're losing that position under load at maximal depth. That's the trigger. So I don't think flexion is inherently dangerous. I think it's the loss of control at the depth of whatever their tolerable squat is with heavier load. That's the most susceptible part. So to your point, train above it, try to maintain your mechanics, whatever your default mechanics are, as good as possible. Really focus on the other factors, but don't make it the boogeyman.
No, I have an old blog from 2016 or 17 where I tried to go through all the literature. And then we did write a paper that tried to review it all. Louis Howe was the first author based on that blog. And I think Louis probably has stronger opinions than me, but I don't know. I think like you choose a side, but be willing to like go to the other side. Or I
Yeah,
mean, my view is I'm choosing a side, but I fully acknowledge that it's just a leap.
yeah. And as evidence comes out and data comes out, be willing to modify what you have. And I've had to do that several times in my career too. So I would assume that's the prudent thing to do. Hey, another boogeyman, knee valgus position. When is it harmful? When is it a normal finding? Do we need to train every youth athlete or every youth female soccer player out of a knee valgus position? Where do you stand on knee valgosity?
It's a pretty neat one. So yes, knee valgus, meaning hip adduction, knee abduction with some rotation, with the knee mostly straight, is associated with ACL injuries, right? But the thing is, what people have to remember, just because someone jumps and they go into knee valgus, that's not really the injury mechanism because their knee is really bent. So yeah, there's valgus, so there's a high knee abduction moment, but the injury mechanism is with a primarily straight knee. The other argument there is the other argument. This is really neat research. Is although so what I'm basing that on is they'll do video. They have videos of where people got ACL injuries, and they're like, look, it's in valgus and it's a straight knee. But what some people have said is that valgus motion is a result of the ACL tearing. Right. That, yeah, it's so cool. Like, although it's within 30 milliseconds, the ACL tore and then they go into valgus. So it's something else. So we've just associated the two and we shouldn't. And then when you look at the pragmatic research where they follow people for years, this would be like Crossheg. If people want to read this stuff all out of Europe, they don't find that you can not predict, that's too strong a word, but you just, when someone has more knee valgus during a drop jump, they aren't more likely to get injured than those that don't. And then the other side to not worry about knee valgus is these great ACL injury prevention studies where they try to teach people to not go into valgus. This would be like the FIFA 11 programs. And these are really successful in reducing injuries, maybe 60 to 70%.
There was a program from University of Cincinnati called Sports Metrics years ago. It was an ACL prevention program tailored for female basketball, female soccer, and several sport programs were introducing it as part of their structured warm-up, like club teams and club organizations looking for a drop in female ACL.
Yeah, the PEP program. I used to do this when I was a strength coach with the women's hockey team. That was actually our conditioning. It was based on this program. And when you look at it, it has Nordic hamstrings, there's plyometrics, there's strength work, there's sprinting, there's multi-directional cutting. And then they talked about changing kinematics and kinetics. And then they helped prevent injuries. But when they go back and measure how people move or the kinetics, the forces, they wouldn't consistently change. So the thing that we thought we had to change didn't really change, but it worked. And so to me, I like that stuff. This is where I'm cherry picking and I'm looking for stuff to enforce my bias. But this is this idea. You just build a really strong and robust system so you can tolerate these normal movement patterns. And then the person's safe, right? But
So
the movement pattern
strength
wasn't the issue.
training. Yeah, good strength training conditioning principles for the win then.
Yeah, that's sort of the idea. And it's great. And then you could say, so whether or not like you would try to change valgus, I don't know if you have to, but I kind of wonder sometimes like, well, why not build other options on how to move? If you're always jumping with your knees caving in or cutting that way, why not be able to do it other ways as well, especially if the sport demands it? And I even had people train into valgus, like rock climbers. That's what they should be doing. It's cool. It's fine. But anyways.
Gotcha. Next on the list, and you probably see this because of the running nature, the enemy of all, the cause of all running injuries, hyperpronation, uncontrolled pronation. Where do we stand on kind of pronation control issues? And before we preface this, if you ever look at elite marathoners, you'd be shocked
Yeah, yeah.
at some of the fastest guys in the world have significant uncontrolled pronation. I'd even say even Usain Bolt in the sprint, who has what a 20-degree scoliosis. If you look at his coming out of the blocks, not pretty, and significant increased pronation. So where do we stand on this topic of pronation injuries, especially lower extremity injuries?
You can take any kinematic or kinetic variable and say, here's a paper that links it with pain. And then you can also take all those variables and say, here's a paper that says it's not linked. So to me, with pronation, it's just it's not worth worrying about. Maybe if it hurts, you can avoid it temporarily, just like anything else, and then build them up to tolerate it again. So I don't know, pronation. Like there's a bunch of famous videos with Haley. You know, he was probably the best runner 20 years ago. Massive amounts of pronation, and had a really long career, just relatively injury free. None of them are injury free because they run 120 miles a week. Recently, there's a Calvin Kiptum one. I have it in my course too, just on the track where like foot's turned out and fully pronating. You know, these we pronate because we absorb load, and then we resupinate or supinate to get a stiffer lever, and we push off. So these to me, they're just normal human variations that we should celebrate. Yeah. Although the funniest thing, let's say you're working with runners and you say you pronate too much, the easiest way to change it would be like take shorter steps. So it's not even, but if you tell them not to pronate as much, or put a block in there, like a different shoe, it doesn't work very well. So
Yeah,
so don't worry about it.
I was going to say cadence and frequency and turnover can matter in ways unintended. And ways unintended is you shorten the stride length, and sometimes you can have significant changes on that variable controlling pronation. But pronation is shock absorption. We need shock absorption. It's a normal
Yeah.
part of the walking motions.
Yeah. Yeah. And again, like everything, if it hurts, you have medial tibial stress syndrome, you could totally tape the foot and have a stiffer shoe or change the gait temporarily. But I don't know why we need to pathologize that motion. You can have like a perfect squat and the knee can hurt. And and perfectly aligned. We wouldn't say never squat this way. We would just say for whatever reason your knee is sore, let's back off of squatting and then build you back up again. It's just we're inconsistent sometimes.
Two more on the topic of biomechanics and again anatomical flaws. I'll put that in quotations.
Yeah. Okay.
Those, yeah,
Yeah.
we're gonna put those in quotations. When is a scoliosis relevant towards pain and dysfunction, and when is it just you got a little bit something doesn't look right on image? Live your life, make yourself a strong and robust human being.
To me, like teenagers, where you're compromising severe, function and organ health and the lungs and all that stuff, which is not my area, but there's definitely, and it's the curve is progressing. There's certainly a role there. So I leave that to the surgeons and those pediatric folks. Once it's stable and you're older, I'm like, it's the same idea. This isn't going back to our first paragraph today was these methods that try to change scoliosis really don't, but they are helpful. And so we'd say, well, what's the good in here? And to me, like you're loading that person up to make them more resilient and all the movements. So I wouldn't avoid going into the curve. You have to bend that way. So train that way. Get strong, long, stiff, powerful, explosive in all of these different positions. So I wouldn't train anyone with scoliosis any different than anybody else. We just would acknowledge what their potential is, or
Okay.
limitations
And
on
then
their potential.
the most evil thing in all humanity, wait for it, leg length discrepancy.
Huh.
Doc, one leg's longer than the other, one leg's shorter. That's the reason why my shoulder hurts. That's the reason why my back hurts. That's the reason why my hip went out.
Yeah.
When is a leg length discrepancy relevant, and when is a leg length discrepancy let sleeping go? I don't need to do anything about it. Just put fear to bed.
I don't even know if this happens, but it's probably relevant if there was some acute injury or something in there. I don't even know, a neurological disorder that changed their leg length, an inch, and then they're not used to it. So it's like just some massive, too much, too soon change. That's probably an issue. But other than that, I'm like, you've probably been like this for decades, and this is a normal amount of human function. It's normal to have this. You mentioned Bolt. There's a really neat video. I think he was out of Weigh-in's biomechanics lab where they measured not just how we run and what it looked like, but they measured the force production side to side. And he is so incredibly asymmetric, But then people will say, well, he did get injured. Maybe he would have been less injured. So even those case studies, I realize they
Yeah, but
double-edged
he's an
sword.
elite. Compare that to an elite level sprinter. And elite level sprinters are like finely tuned race cars. They're all of them are subject to it because of the force production, the rate of force, the amount of force, deceleration. All of them are prone to significant injuries. So are
Yeah.
his injuries more prominent? Missed more days of training, missed, like are those variables any more significant than an already established elite level sprinter? I don't know the answer to that question. I know he
No,
was asymmetrical, but he was the best in the world and he had this massive asymmetry. Theoretically, that shouldn't happen. It did. So the asymmetry didn't matter in terms of performance. It mattered for injury. I don't know. I don't know the answer to that.
I mean, when you look at when they try to measure it, it's not associated. I think that the problem with imbalances, that word, is yes, that shows up in the research. Like for hockey players, you might find an imbalance in strength between the adductors and the abductors, but it doesn't mean it's because side is stronger than the other. It's more that when you have that imbalance, it implies there's a weakness in there. We just don't have any other way to report that the person's weak. If we had an absolute, so here's the thing, like I just saw this video on a golfer yesterday on YouTube with this famous trainer, and they're measuring his jumping and the asymmetry left to right. I said, oh, we got to address those imbalances, because there's a 20% difference. And I'm like, so would it be better if you if you shot an injection into that stronger side to make it 20% weaker? And now they're balanced. Is that person now more likely to get injured? Or what if both sides got 20% stronger? Would that be better? They're both stronger and hence more robust, you would assume, but they're still out of balance. So I think we have to be
It's
careful when it comes to imbalance there.
Yeah, it's a slippery slope. Some of those imbalances are actually performance enhancing. Like, for
Yeah.
example, your right handed pitchers in baseball, your left handed pitchers in baseball, they are completely asymmetrical. They do the same thing over and over and over and over again. But that gives them the sports performance. And if you start tinkering with that in the in season or off season, you may reduce their performance. You may be more symmetrical in terms of force production, but does that asymmetry lead to the increased performance? And is doing that, did you open up a Pandora's box? It's a really interesting, fascinating, field. And I don't think there's clear cut answers. And I think it comes down to it depends on the athlete. The only thing I will say is if you have that asymmetry and you can tie as best as possible with your history and exam, asymmetry towards, pain or limitation and function from an athlete's peak form, you got to do something to address it. But I don't tinker as much as I once used to because you may open up that Pandora's box and make it worse inadvertently. And then they don't like you.
Yeah.
So you mentioned a couple of times, directly or indirectly, this concept and this topic in the clinical rehab world of symptom modification, aided exposure, and then using exercise for those tools. Can you give me an example of how you've used this in the past with either like a case study or a patient or an athlete that you've kind of worked through graded exposure, symptom modification, and then building up to build a robust human being?
Yeah, so graded exposure at its simplest is you find something that someone is avoiding, a meaningful activity or movement that's, relevant to them. And you kind of make the guess that this is them not doing this motion is part of them not recovering. So the most famous would be like spine flexion. So when you have someone pick something up from the ground, they're like, oh, my back hurts when I lean over and I pick stuff up. And you look at how they're doing it and they're guarded, they're braced, they're rigid, so they're avoiding spine flexion. And then what we would say is they're actually an endurance coper here. They keep doing the same thing over and over, which is holding their spine in neutral rigidity, and they're avoiding healthy movement. So graded exposure would be like, we have to get you bending your spine again. It's no more complicated than that. The challenge is like, where do you start, right? And there's a really good chance that they're going to flare up because they haven't bent their spine in years. They're terrified of it. They think that bending over to tie their shoe will make them be in bed the next 4 days, or their disc is going to go, or something like that. So it's psychologically scary, right? And for the person treating them, right? You don't want to flare people up. So that's just classic exposure, is just slowly doing these things. And you could say that's part of symptom modification, because ideally when you do exposure, you can get really lucky sometimes where like they breathe, they relax, and they say, oh my God, I can't believe I'm touching my toes and my back doesn't hurt. because you've done it differently, or they trust you, or they start to trust themselves. So that's also symptom modification. So exposure technically is doing something that you're afraid of, that you've been avoiding. Symptom modification, sometimes, this is like your classic McGill or Shirley Sarman, mobilization with movement, and Mulligan. It's like, hey, we found this pattern that hurts. How about we don't do that? Let me teach you another way to move so that you don't extend your hip as much, or your Achilles hurts when you run, so we're going to run on your heel and not your forefoot, or your knee hurts when you run, so we'll take the nuclear option and teach you to run on your forefoot and not your heel, right? Or when you deadlift, you're really arched a lot. Just let your back round a little bit, and this is me, and it feels way better. So symptom modification is fun. It's amazing. You probably have patients like, you're like, why didn't you just do it differently? And it never occurred to them to move differently. And then it's classic Shirley Sarman, right? I'll teach you other ways to move, and then keep doing lots of that. And then exercises that help facilitate that new movement pattern, because it's not easy to change how you move. That's for sure.
Yeah, it's motor learning, and motor learning is a product of thousands, if not millions, of repetitions in a finite amount of time to start to groove the hinges that it just becomes your default. But
Yeah.
it's not painful, like physically painful. It's painful to watch because you literally have to teach somebody how to chew gum and walk or tie their shoe over again
Yeah.
instead of crossing right over left, left over right when they've done it millions of times like that before.
So that's it. It's like the ideas behind it are simple. Find the things that hurt. Don't do that. Like there's the philosophy, but that's not necessarily, might be simple. It's not necessarily easy.
Yeah. 100%, 100% agree. We keep harping back to building a robust human being, whether it's the soccer player that lands in knee valgus with, femoral adduction. If she's robust enough, she can handle that position. We may not train the biomechanics out, but we make her robust and adapted. What are your 2 or 3 best tools, whether it's a specific type of exercise or lift or advice, to be a more robust human being?
So there's 2 ideas here. You say, like, what is it that you have to do? Like, what are you training for? So you understand the demands of the task and build someone up to do that. If people are already doing that, we say, what aren't you doing? Let's do that. And then, sort of the third one, what do you suck at? Oh, okay, well, let's do more of that. That's kind of the strength coach in a nutshell there, right? And so
Yeah.
that's it. And so the challenge is, like, where do you spend your time? I, like, in my course, one thing we do is tell everyone, okay, create a 3 to 4 exercise program for the lower body, and you're the health dictator of Austin, Texas, because you guys are socialists like we are here in Canada, and you're gonna make all the school kids do it. And so what would that look like? Can you do that with 4 exercises that prepares someone to do everything? That's like
What would
the
be your
simple
4?
idea. I've kind of challenged myself lately. I was like, before I'd be like, okay, deadlift with primarily, like, make sure you have a hip hinge. So we get, like, the glutes in there and the back, and you're pulling. And then, like, a lunge, just to make sure you get the quads and, like, you don't spare one quad. Because if you do a squat, you can kind of favor one side. And then just like a heavy calf raise, right? So I would just choose 3, and then, because I want people to say, well, what are we missing there? What we're missing there would be, like, the so and when you do that lunge, it's more like a rear foot elevated split squat, where the rear
Bulgarian?
foot, yeah. I never use those. I'm not a big fan of Eastern Europe. Just kidding. I don't know why I said that. I like Eastern Europe. You guys are great. Don't know why we have to call basic exercises after a whole country. Are you Bulgarian? I just insult your
No,
heritage.
I'm Greek. No, you
Same,
said insulted Eastern Europe. You could
same.
throw me in there. Is
Okay.
yeah, but or
It's
Romanian deadlift. There you go, another one.
Yeah. Well, I always get them confused. So there we would say, what aren't we getting? We're not really getting the side of the hip, so glute med. So when you do that Bulgarian split squat, you want to have, like, a really light foot in the back, because then you have that moment into frontal plane. And then the problem with the deadlift there is, are you really training the hamstrings if you do your deadlifts the way I do them, which is very knee bending? I'm bending forward. So you'd have to do a Romanian deadlift. But anyway, that's the exercises, like, what we get you. So those are mine. So I would wonder, what if I replace the lunge with, like, and the deadlift with just a trap bar deadlift with a squatty style, and then something more specific for the hamstrings, and then the hip flexors and the calves. And then what's great is you just complement those with a fast motion to get power. So now cut the weight and do it faster, or no weight and jump.
Sure. Power is a product of force development, speed. The faster you move, the more power you develop.
Yeah, yeah, yeah. So those are the ones I would
I'm
always go after.
I'm a keep it simple guy. Push something, pull something, hinge,
Yeah,
squat, and carry. And there's your
yeah.
five for life, right?
It's just with
So,
those, I would say, like, are you getting your, this is where I always wonder how specific you have to be, right? It's always my challenge. Are you getting the calves enough? You could say maybe carrying if you carry it uphill. I don't know, and are you getting the hamstrings? Like it depends on your hinge, right? My deadlift is leaning forward a lot, but I squat a lot. Like I don't do a Romanian. So am I really getting my hamstrings? I don't know. But anyways,
and I'll
those things are fun. Those exercises are fun to think of.
Yeah, my top four for runners. I know you're into the running resiliency program and course is I'll recommend for most runners. If they just ask me for a general strength training conditioning program to build a robust runner. I'll do multi directional step ups, one step sagittal, one step transverse, one step lateral. I'll do single leg deadlifts. I'll do Bulgarian split squat. And then what I'll do is one power movement. And the power movement will be something like low weight kettlebell swing. So now I've got multiplanar movement, sagittal movement in single leg stance. So that's the single leg deadlift. Sagittal movement in split stance, and something to develop power, which is low weight, move the weight in the kettlebell swing. And those are usually what I recommend for my runners. Sometimes I'll substitute in a squat pattern as well and play around with it, goblet squat, or play around with kettlebell rack squats. But those are my four for runners. Is you've got knee dominant, you've got hip dominant pattern, you've got multi-directional pattern, you've got something for power, and then something in split stance. And that's what I recommend most runners to do. How about you?
Yeah. Uh, yeah, very similar. I would just add focal calf training just for the Achilles. We just know as people age, their Achilles tendon tends to get less stiff and they lose a lot of calf power. So maybe that would
Gotcha.
be the only thing. And then I would do the same thing if someone golfed. That's my first passion. A
Oh,
golf
it's golf.
I would I published a paper 20 years ago for golf training and I still stand by it. Your strength and conditioning program for golf looks 90% like your strength and conditioning program for running. It's like this is what I love about simple fundamentals, right? Where because they're going to get golf specific motions on the golf course and the driving range. That's where you train speed. You get strong and powerful in the gym. You could add a little bit of rotational core stuff in the gym, but not much. It's primarily squats, deadlift, lunges, single leg deadlifts, everything you said. Yeah.
Yeah, that's what I was going to ask. Any rotational core stuff, payoffs, rotational planks or anything? The answer is yeah, a little bit.
Yeah, but I would do I know people talk about resisting motion. I would create the motion under load. I
So
like
more
that
like a
stuff.
wood chop or a lift,
Wood chop,
more so than a payoff.
yeah, yeah.
Yeah,
Med
wood
ball
chop
throws,
coming down, lift is coming up in a
yeah.
diagonal pattern.
Or just make something
Cool.
go right in between the two. Just be more efficient. Just rotate, punch.
Two more two more questions really quick. There was something I read in on your website and something I think you allude to in your course, the comprehensive capacity model. I'm not quite sure what is that model
We
and what
just
do you mean by
We
comprehensive
just did it. We
capacity?
just did it. It just sort of says like, I don't know what has to change with people. I wish I did. Everyone pretends like we're mechanics. Like here, this is the exact problem. This is you need to get stronger. You need to get more powerful. We need to change tendon stiffness. You need more mobility. I can't be sure. And so I'd rather say, let's just build up the whole system. That way, what the problem, capacity, the knock of the word is it's so general, but that's also the strength of the word because people say, what do you mean by capacity? I mean everything. And so it just sort of says, I can't be sure what has to change. So let's build a robust system, healthy system. So in his class, you see it all the time, right? If someone has knee pain, we do knee exercises, we do hip exercises, we do foot exercises. Someone has Achilles pain, you do foot exercises, knee exercises, and hip exercises. Someone tears their hamstring, you don't just do hamstring exercises. Someone hurts their shoulder, you don't just do shoulder, right? Everyone does this. So I'm not like inventing anything here. Just sort of saying, what's the common thread among so many different people? And it's like full system work. And then you debate the best way to do that for that person in front of you. Yeah.
Gotcha. Last major question. Closing thoughts and remarks. What would you want our audience to take away from this approximately 1 hour conversation that we've kind of had on this topic, reconciling biomechanics with pain science, building robust human beings? What are your three major takeaways?
My main thing is like people in my field, like in the education field, I'm warning you against me because I hope I try not to do this. We overcomplicate things. I swear to make people feel stupid. Like that's what bugs me with the pain science stuff. Like people will be like, you need to be a neuroscientist. You need to read all this stuff on pain science. You need to understand psychologically informed practice. And they make it like way harder than it needs to be. And I'm like, no, you don't. Very simple messages go a long way. Very simple. The basics are just like with your exercise program there. The basics will go incredibly far. So that's both in terms of biomechanics and strength training and understanding pain. The basics will go a long way. If you read Explain Pain or simple books like that, you're good. Or my book. Sorry, I have a book. That's the best one. It's free. It's on my website. It's called Recover. I forgot about
Three
mine,
ninety
but
nine.
it's free. No, it's straight up free. Like, and I don't even need your name. Like, you just download it. There's no like, give me your email. I'll bug you for life. It's the best one because it does try to be simple, right? So same thing, like get your fundamentals and then just feel confident. You got this. And then you get those fundamentals down and of course you'll decorate, slightly different with areas where you're going to, embellish and get a little bit better at. But feel comfortable with the basics going along.
Two other questions here. Upcoming course schedule. I know that you teach. I know that you've taught several different countries, actually several different continents, if memory serves me correct. What's upcoming for you?
I try. Yeah, I haven't been in Antarctica or Africa. That's it though. Like I'm in
I
Taiwan
got
a
news
couple
for you.
weeks
It's
from
going to
now.
be hard to schedule a course in Antarctica.
Yeah, it's not happening. But I have been to Nunavut, which is Iqaluit, which is like the next best thing. It's the Canadian Arctic. That was cool.
Oh man.
For 6 people. It was better for them to fly me there than for them to fly down here to a course. And I was like, okay, I'll go for the weekend to the Arctic in
Yeah,
May.
I'm game.
Yeah. So I was just in Dallas. Haven't been to Austin. So where am I next little bit? But Burnaby. I'm always in the States. I'm in Seattle in April. I'm in Walla Walla. That's like in Washington, I think.
Washington
Sorry.
State.
Yeah. I'm excited about that. I'm in North Carolina for the first time ever. I'm in Nashville. That's going to be really cool in May. So those are the big American ones. And Taiwan in a couple weeks somewhere. It's all on my website.
I'll post
I
the
get around.
links to your upcoming course schedule and the website in the show notes here. And Greg, if people have questions on this topic, reconciling biomechanics of pain science, running resiliency, or anything we talked about, where can people find you?
Well, greglehman.ca, and then Twitter, I'm probably on the most. And that's Greg Lehman. That's the easiest. I still find that one of the best way for continuing education because you can have good discussions on there. Usually,
It's
if
a
you have like
town
a
hall
good group.
back and forth.
If people go into it with the not trying to score points, but to be like, hey, I don't understand this. What's going on? What's everyone else's thoughts? Sometimes it turns into a cesspool, but I find you can cultivate your feed to be healthy. Not that I don't engage in negative stuff sometimes, but I can always be better.
All right. We'll post your X or Twitter page on there, YouTube or Instagram or Facebook, any of those, Greg?
So I've been meaning, I have one project I gotta finish and then I'm doubling down on YouTube. I did a lot on YouTube before of like messages about pain, but I'm going to take my book, the recovery book, and put it all on YouTube because I think a 3 to 5 minute video of someone else saying the same thing that everyone might say to their patients is still helpful. I like, there's no new messages, but it's great when people hear the same thing over and over but from other people. So I'm doing like a little project where people tell me like, what do you always say to your patients? Okay, well, I'll say that for them, but with some graphics for you.
Yeah, I have a seven minute video that I will send on chronic pain that I found. It was an Australian video, and it's kind of like somebody drawing on the chalkboard
Oh
and
yeah.
walking through what is chronic pain. Yeah, you've probably seen it, and I send that to my chronic pain patients. They say thank you, and I'm like, that's literally what I explained for about 15 or 20 minutes in here.
Mm-hmm.
And that 7 minutes gives them more information than me giving to them. And sometimes I'll have a conversation is I'm not going to talk about chronic pain today. I'm going to talk about your needs, your wants, your goals, your fears, and how do we start this process in here. I'm going to send you this homework assignment that's mandatory. That's a 7 minute video that I want you to watch. And then this will lead into the next conversation. And I found that that has been more effective than me giving them that information and then later sending them that video. So to your point, I think your chronic pain video is going to do well with the right demographic.
Yeah. Agreed.
Yeah. Well, I want to say, Doc, thank you for your time. We appreciate you, appreciate your talent and your expertise. Thank you for sharing with our audience and with me personally so we can all up our clinical games.
Okay.
I'm Dr. Dino Pappas. This is Dr. Greg Lehman. We are signing out.
Thank you.
Thank you, sir.